Much better. Good morning, everyone. Thank you so much, Sandy, for inviting me. And first, I want to start by asking you, how many of you were up late last night watching CNN? And how many of you were listening to NPR or other stations on your way in? Right? I'm obsessed with this. This is an amazing time that we live in. So thank you for allowing us the opportunity to break into your news today with some information about the Area Agency on Aging. And it is my pleasure to be here today. And what I'd like to do, first of all, is check, am I clicking the slides? Sandy? Oh, okay, thank you. By the way, I have a job very similar to Sandy's where I'm working with a commission and working with guest speakers, and it's always so complicated to try to keep everything running. So you've organized this beautifully. You should be able to just arrow down. There we go. So what I'd like to do today is provide an overview of my group, the Area Agency on Aging, talk a little bit about aging in the county, and also share with you the results of a recent planning effort that we've undergone, and have done so, by the way, in partnership with Wendy Peterson and the Senior Services Coalition and many other people, and Wendy will be able to speak to that effort and advocacy in general. I'd like to begin by really just providing you an overview of what aging looks like in our county. So what you can see on this chart is that the number of older adults, and in this case the older adults are 65 years and older, is tripling in a 5-decade period. And this becomes really meaningful for us in the delivery of services and the policy that we establish. By 2030, 1 in 5 Alameda County residents will be 65 years or older. If we look at it another way, we can also see that this trending of more older adults continues. So that, again, in the growth in population between, as you can see, 1970 and 2010, the growth in 65 plus age people is 70%. And the growth is 90% in the 55 to 64 population. Now here's something really interesting from a policy perspective. And this is policy where we haven't kept up with demographics. By 2040, which is not really that long from now, when I think back, I've been married to my husband for 27 years. It seemed impossible for me to imagine when I married him what it would be like 27 years later, and it happened so quickly, right? So by 2040, we will have more older adults than kids, than children under the age of 18. And that's really important. Certainly, we don't have the funding at this point for social supports, long-term care services supports for older adults. And by 2050, in Alameda County, we're going to have 100,000 people over the age of 85. Now, one of the things that I do in my role is I oversee the Ombudsman program. So we have statistics on the number of long-term care facilities, and I am the first to say, as a person moving into this older adult category, the last thing I hope for myself, my family, my friends, my community is that there's a long stay in, say, skilled nursing. That is not what we're looking for. However, realistically, about 50% of the older adults, the 90 plus, end up having a stay in a skilled nursing facility. Right now, in the entire county, we have 13,000 beds. Now remember that, again, in the not too distant future, we're going to have 100,000 people over the age of 85. Oops. I think and we are perfectly fine though. So I also want to give you a picture of poverty in older adults. And by the way, these slides are all presented for us by Alameda County's healthcare services agency. They have a unit that provides data. So what we look like in terms of poverty is, you probably all know this, that the federal poverty guidelines are now, I don't know, for a single adult, 11,000.
1,006 a month.
Yeah, so not much money each year, and that's considered poverty. If we use the federal poverty standards, on paper, only 11% of our older adults are impoverished. If we look at what the Elder Economic Index says, which really takes a look at what do you actually need to live on, what kind of money do you need to live on in this county, we really get to a place where it's more like 50% of our older adults do not have enough money to live on. And certainly when we look at housing, everyone in this room is aware of the enormous issue of housing. Our seniors do not make enough money through their retirement and their pensions to even pay for a one-bedroom apartment. We are highly concerned about this. So if we look at demographics, certainly a topic of conversation with our because of our new administration. No surprise, older adults are skewed toward female. We outlive men. I'm not sure why, but we do. And in terms of Alameda County, Caucasians are a slight minority at 48% of the population. Now, how this really plays out, if we move into the next slide, is when we look at our older adults, both by place of birth and language spoken at home, 38% of our older adults at this time are foreign born, and 10% are not US citizens. 40% speak a language other than English at home. So this is really important, again, for service delivery and access to services. Our studies show that older adults who are immigrants tend to have less personal income than native-born counterparts. And also, certainly, we understand in the delivery of services that many of our immigrant older adults are just not comfortable accessing services. The next slide also came about as a result of our planning effort, and I'll talk about that in a little bit. But this slide shows the older adult disability status. And this is a really meaningful slide to me. One of the topics of conversation that came up in our planning effort was really driven in part by the head of the Alameda County Public Authority, who shared the premise with me that one frequently ages into disability. And certainly what we can see by this chart, what we're looking at is the percentage of adults that have a disability, and you can see the skyrocketing percent as one ages. So in case you can't see the screen, in the 18 to 34 age bracket, 4% of people have a disability. That skyrockets to 51% by the time one is 75 or older. This concept of age and functional limitations and disability really hits home for me. So I'm not quite an older adult, close. No reason to disclose when I hit that magic mark of 60, but 10 months ago I had an accident. That resulted in surgery, that resulted in a neurological condition. I've made great progress and hope to continue to make progress, but you know, I had certainly months of coming to grips with an unexpected disability. For a long time, I couldn't tie my shoes. There was a really big day for me, the day when I was able to, because it was involved with my hand, I was able to actually use my finger again for Amazon. Like I couldn't cook, I couldn't tie my shoes. Forgive me for the men, I don't want to be indiscreet, but for the women in this room, you know, like when you can't clasp your own bra, right? So, and I had a moment where I was at this point back at work, part-time, really struggling with physical therapy and my limitations. And I decided to take Bart to meet my niece at the airport. And I am right-hand dominant, and I was loaded up on my left side like we all do when you have your backpacks and your purses and your laptops. And I was trying to put a dollar bill, into the BART machine. And I couldn't quite do it, partly because the dollar bill was crinkled and partly because my fingers just weren't working. And I heard, tried 2 and 3 times, and I heard someone behind me give me a really annoyed sigh. You've heard of that. And I kept trying, and then she walked up and just put the money in for me and walked away. And I had this moment, and I thought, wow, I've just been shamed. Now, have I been shamed because I'm old or because I have a disability or both? And it's just bringing home to me that as we do our work together with the aging and with the disability world, we've got to look together at planning and its services, its design, its cultural sensitivity. So I'm kind of all over this one. Finally, keeping on the information about older adults, types of disabilities, this is what the Alameda County Department has come up in terms of what types of disability people have in Alameda County. And the most common types of disability are ambulatory and independent living difficulties, followed by hearing and self-care. So that's a picture about, sort of the big picture of what we see aging looks like in Alameda County.
Tracy, would you mind telling folks where this information came from, the data in this slide?
Yes, the data in this slide came from our, it's called CAPE Department. So it's the Alameda County Public Health Department. And the source that they've used is the American Community Survey in 2014. All of this data, by the way, and more, is available for you in the area plan that we'll talk about. And these resources are also sent to you, and we can also give you access online if you would like. And very specifically in the area plan, there's data, some data on every single city, and lots of big picture data as well.
There are a few copies back there, but if you're interested, I'm happy to email that out. It's a very interesting report.
Thank you. Wendy and I are proud. I'm glad you think so. So, having talked a little bit about the big picture of aging, I want to talk with you a little bit about my group. So, I am a county employee. You can recognize that because I have a badge. I'm within the Department of Adult and Aging, located in the Eastmont Mall. We have and you're right, the Area Agency on Aging is difficult to, it's a little bit of a tongue twister. So you will hear me refer to us as the AAA, and you may as well. So our AAA is one of 33 AAAs in the state of California. Many of those AAAs are nonprofits. We happen to be government-based. And we do have a state association, and I'm a member of that executive board. Our philosophy at our AAA is that the best way to deliver services is in partnership with community-based organizations and with other public jurisdictions, mostly community-based organizations. That's an organizational philosophy, and it's a personal philosophy. I come from the nonprofit world and know that nonprofits can be more facile and responsive than sometimes our government can be. And I am part of our government. We are governed by the Board of Supervisors. We administer 72 contracts, and we serve approximately 65,000 people on an annual basis through a myriad of funding streams. So what is it that we do? Well, one of the things that we do is we do lead the planning effort for older adults in Alameda County, and we do this every 4 years. And as referenced, we really are proud of our last planning effort, which covered the period from July 16 through June 2020. We provide technical assistance and oversee the distribution of Older Americans Act funds. I would imagine, Sandy, that you work a lot with different funding and constraints, and every single bit of funding has rules and reporting requirements and descriptions of what you can and cannot do. So part of our job is to help our CBOs, our community-based organizations, understand those constraints. And finally, it's super important that we provide monitoring of all of our contracts. We provide fiscal monitoring, program monitoring, and with our nutrition contracts for home delivered meals and congregate meals, nutritional compliance monitoring. So in terms of scope, we do work with 38 organizations, 72 contracts, 18 programs. We competitively bid every 4 years. We will go out to bid in January of 2018. So I see that some of you are with nonprofit organizations. You'll want to pay attention to that bid when it comes out. It is an open and competitive process, and be happy to talk with you if you have questions about that. And I can talk with you up until the moment that we release the bid. And then all conversations occur in public meetings and they're noted. But I'm more than happy to talk with you before then. In our next slide, I just wanted to give you a picture of the sort of services that we offer. And the services, I want to note something. So Ron is not here, and I was looking, oh, you are, Ron. So I worked with Ron's predecessor, Sherry Burns, and Thomas Gregory from CIL. And we worked on a project a couple of years ago where the three organizations, those two organizations and the AAA, partnered in order to apply for funds to pursue whether we could develop an aging and disability resource center or connection, and then we applied for funds to achieve our designation. Now this is sort of one of those weird things where we did a whole lot of work. Immense effort from all. We did achieve that designation. There is no funding. So right now, we have the name of an ADRC, and we hope, Ron, at some point to reconvene and figure out what does that mean for our community, because the premise that there should be no wrong door, and that whether the question is related to disability or related to aging, that people should be able to easily access information and services, that is an extraordinarily good premise. We just have some work to do on implementation. But I say this as background because one of the first things I learned as a newbie coming in from aging and working with CIL and CRIL is that the concept of case management was not a concept well received in within those organizations. So I just want to let you know that I'm aware of that. In the aging world, we still have case management contracts, but I don't want to appear insensitive to what the really good information that I've heard. So we deliver lots of services. These services are not means tested because most of them are funded through the Older Americans Act. We are required to fund services for the population of 60-year-olds and older, but we cannot, and we are looking to serve our most needy clients, the clients that are economically disadvantaged, that have functional limitations, that are of minority populations, but no means tested. So unlike in-home support services, if you have a client that needs a meal, and if we have enough funding to start that delivery of meal for home delivered meals, then we do it. Your client doesn't have to prove any income status, and I think that's important. On the meals front, we, through our home delivered and congregate meal programs, serve 750,000 meals a year. We fund a number of senior centers, family caregiver support, and that, by the way, for you nonprofits, that's an area where I would really be interested in receiving more responses when we go out to bid next time. I think that we could expand our services a little bit. We are this year piloting evidence-based programs for falls prevention and health management. We're looking at, we're funding Tai Chi programs, Matter of Balance programs. We have a new program that is a home-based home meds program. So we have non-clinicians enter in medications, and then we can, a pharmacist review those. So lots of stuff going on with the AAA this year.
Could I interject? Do you mind? And bless you, Tracy. I am so glad she mentioned that she could open up bids to nonprofits that are here. Because we started the conversation at our last flood planning meeting about really looking at senior supports and services for individuals with with developmental disabilities. And this is just an example, but I think it's an important one, how we can work with the county and collaborate with them. And thank you very much for mentioning that.
I was just curious if it would make sense to do a presentation to feedback prior to having the bids go out, because vendors, that would be a good place to let vendors know about something.
It's a provider group.
I am more than happy to. Yes, and my top level hints for any nonprofits that submit bids, it's really important in your responses that you describe fully your services for 60 plus, and then to really describe very fully and thoroughly how you meet the requirements as outlined in the bid. So staff, when the bids come in, we have community groups that evaluate the bids, and it's a large scale effort. You know, because we're bidding on so many programs and so many contractors come in, I have seen the case where organizations who I know to be good and strong organizations are not responsive to the bid questions. So I beg of you, yes, I'll speak to that group. Yes, we always do pre-bid conferences, and that's really important, because even when I've seen organizations that I like, if they're not responsive to the bid, as staff, we are not able to outweigh the bid scorings. So by all means, glad you asked that question. All right, so that was a little bit about the AAA, and I just want to give a top-level view of the results of our big planning effort. So we did something new this last time. We assembled a team of about 25 members of a planning committee, and that was really important. Those members included nonprofits, cities, consumers, lots of people who had fresh eyes and helped us with our approach. One of the things that I'm really, really proud about is that we were able to develop and disseminate a consumer survey. And loosely, that survey was based on some of the precepts of the World Health Organization's age-friendly communities. Do any of you raise your hands if you've heard of the WHO age-friendly communities? Oh, okay, so just a couple. It's basically a framework to build out communities in a way that is friendly to aged and community in general. So we built this survey, and as you can see, we received 3,725 valid responses. Valid meaning older adult resident of Alameda County, and those responses largely mirrored the demographics of race and economic status and gender of our county. So really good sampling. We also had a number of public forums, as you can see, lots of public meetings, and we were able to incorporate data analysis from our county's CAPE team and other sources. So what did we find out? Hold on. We found out that the number one concern is really, as you can see, it's money and housing. And those two things right now are the same thing. So the average rating is a rating scale, but this is the first time in all of our planning efforts where we've seen income as housing in such a strong lead in terms of concerns. And I can share with you that one of the things our group does is we have an information and assistance unit. So we have a person who answers calls. It used to be in the old days that the call was, I'm calling because my mom needs help. She's starting to have dementia. She's not able to attend to her affairs at home. How can I get help? And I'm worried that she can't afford her place. I'm worried I can't afford her place. The calls that we get now are, I am homeless, or I'm going to be homeless in 2 weeks, and what do I do? and you know, Wendy can speak to this, we were on a call about exactly this topic yesterday. It's really frightening because there's not a great answer. And there is truly not a great answer in terms of homeless and older adults. And maybe if you don't mind, were you planning on sharing some of the conversation yesterday?
No, I wasn't, but I was hoping we could come up with a question and answer so we can talk about that.
I'll pose a question, or I'll cheat. So, you know, one of the things that we talked about yesterday is that for older adults who are homeless, who are, you know, out on the street, they don't want to go to shelters, and part of the reason is they can't use shelters. They can't get themselves, they can't bend down and get in cots. They can't bring in their meds.
Right, and there isn't a safe place to put all their meds. Yeah, the food doesn't work for them. I mean, it really is a whole host of barriers to older adults. So the shelters don't work, and that means that the homeless encampments are preferable. Right?
Yeah, that's what we're hearing.
This was a call that was a collaborative effort between the Alameda Health System, which is the county's hospital system, Healthcare Services Agency with public health and behavioral health and health care for the homeless, and the area agency on aging and adult and aging services, and community-based organizations. So everybody is working to understand what's different about older adults and homeless older adults and older adults who are facing displacement, and making sure that those needs are addressed as the county is planning their regional housing resource centers and other interventions.
Thank you.
I have a question about this homeless business. I recently found out that a lot of, I won't say a lot, there are cities that don't want shelters, so they think that they deter, I guess. If they don't have them, then they won't have as many homeless. That's my and so that the city's kind of involved in this too, I guess.
And I'll repeat the question so that everybody can hear. It's a question/statement that you've heard that many cities are not in favor of shelters in their cities. And so that, if I may paraphrase, that becomes part of the problem. And I certainly think from a county perspective, we've seen that. We have a woeful lack of resources. And I'm less familiar with the cities, but that doesn't surprise me in any way.
And there's a lot of variation from one city to the next.
Right.
I will say a hopeful sign. Alameda Healthcare Services Agency has convened regular meetings of all the cities to look at health issues, and they zeroed in almost immediately on homelessness and homeless encampments because it's impacting every single city. And so there's working done, conversations that I think they're already leading to some collaborative work.
That sounds good.
It doesn't move fast enough though.
Right. Yeah, it doesn't hit the people who call our office and say, I don't have a place to stay tonight. Back to the survey, we look at the top 6 or so, and it's housing, income, and then there's something really interesting, being included in making decisions that affect your lifestyle. And that really cuts to the heart of matter, that people want to be in control of their own lifestyle. I strongly agree. And being concerned about falling. So those were the top concerns. And I'm going to wrap up so we might have time for questions. What were our key findings in this overall planning process? Well, obviously we've covered, there's more older adults. I used to paraphrase this, more old, poor, right? More poor old people. That's it. That's all you need to know. We have a lot of, the ages are, the numbers are increasing, and as is poverty. Preventative health is key. We do have data in our plan that shows that many of our long-term chronic conditions can be helped or mitigated by prevention, and that's why we're so big into evidence-based exercise programs right now. Obviously, housing is a huge concern. I was not aware until looking at our own planning effort that nutrition insecurity is enormous. 1 in 5 calls to the food bank are from older adults who don't have food right now. Not, like no food on the shelf. As we've discussed, disability is an increasing factor. And the silent, horrible issue of elder abuse that's growing, widely unreported. And in my work overseeing the Ombudsman program, I see this all the time, that our elderly residents do not want to report their own children. So the children are taking advantage of them, and there's so much family shame and family concern. And finally, I won't read through the goals, but we have established some main goals that we as a county and as a collaborative are working hard on as we speak. So I think, shall I turn it over to Wendy and then questions, or?
Do people have questions now for Tracy? Shall we just see? No, not now? Okay. Let's go to, put your mic for a second.
Let's go to Wendy now, but I'd like to preface this because I said I knew Wendy before because we worked together on a project called CAB, which you may remember what that stands for. I do not. We worked with the Center on Disability at the Public Health Institute. One of the programs there is the ADA Pacific Center, which I'm sure many of you are familiar with. So we worked with a gentleman, the deputy director there, Louis Krause. And Louis was wonderful. And I bring this up for a couple of reasons. One is I pointed out the data. I wanted you to mention where that came from. Well, the Public Health Department, I've probably mentioned this before, is going through a national accreditation process. It is long, laborious. And one of the things that they had to come out with was a Alameda County resident profile. So I was reading through it. This was a few years ago, and I noticed there was no data about people with disabilities or seniors at that time. So I sent Dr. Davis a little email, gee, where is this? And then he copied the head of our epidemiology department, and through a period of time, they've made some wonderful strides in data collection because, as we know, data drives resources, right? So now, the reason I'm not going to be at the July planning meeting is because we're going to present what we've done here in Alameda County, because we're not only just moving now towards the data collection, we're moving towards training. We're contracting with Louis and the Center on Disability to come in and teach disability cultural competence to the public health programs so they can offer preventative programming and know how to address the needs of our community. Anyway, I just want to preface.
Thank you, Sandy. Good morning, everyone.
I'll bring your presentation up here in a second.
Sure.
Unless Claudia's going to do it quick.
And I really appreciate having internal advocates within the public entities in the community. I think it's important for advocacy to happen from the inside, and that's a really good example of recognizing that the data isn't there for some people, and therefore they're invisible to the policymakers. What I'm going to talk with you about, a shorter presentation, really about the Senior Services Coalition, but more about how important it is to have partners working in all of the different sectors, working together to a common end. And I think that Tracy and me being here today is a really great example of how you've really got to do that. You have to recognize champions, you have to understand who your partners are, and you need to figure out common ground so that you can move forward in order to serve the people who need to be served. So today I'm going to talk about our coalition approach to putting aging services on the radar. Because I think, to sum it up, that's sort of what the Senior Services Coalition does. So we are a coalition that's been around for a long time, since 1996. We're a true coalition. We're staffed now. We've been staffed since 2001. But it really is not, it doesn't have a building. It doesn't have a set of services. It's not even a 501c3. It is 40 organizations that come together and work for a common set of priorities in order to improve the lives of seniors in Alameda County. So these 40 organizations, you notice that they provide health and supportive services to over 65,000 older adults in Alameda County. That number should be familiar to you because that's the 65,000 that Tracy reports from the Area Agency on Aging. And we do kind of use that number. And I know that the number is larger than that, but that's the one that we have data for. So it's like, thank you for the data. And we really have a vision that we've articulated over time. When we started in 1996, we came together because we had a really big, important problem to work on together. And we had never worked on anything together before. But at that time, it was the AAA that was reorganizing the funding allocations for different parts of the county. And that meant that funding was leaving some places and going to other places. And so all of the different organizations that contracted at that time with the county were up in arms. And they were walking into Tracy's predecessor's office, day after day. And Joe Rodriguez, who some of you know, was wise enough to say, you know what? Why don't you get your act together, guys? Meet, figure out a common unified message, because we can't have all of these different organizations speaking to us. And so they did. And that was the genesis of the Senior Services Coalition. In the process, they realized there was so much common ground and there was so much opportunity to share best practices. They continued to meet after that. And so I do think that coalitions often need a crisis or a really pressing emergency in order to jumpstart their activities, but I don't think that that is essential. So as we have morphed, that vision, we have developed a vision, we've evolved our mandate and our scope of work. We've become very advocacy oriented. We've been tempered in the fires of many state budget crises. So when we started out, we were not about advocacy. We learned in the first decade of the new century, we really learned how to do advocacy at the state level, especially. And we developed a vision, which is a county where people can age in place and live with dignity and be part of the community, feel safe. It's really, we all want that for ourselves and for the people in our neighborhoods and communities. So our mandate. I think I would describe a three-pronged policy agenda that is around, it's pretty simple, it's around funding. Relevant, reliable funding that is adequate to serve the community. And funding for community-based services. So our membership are not, they all think of themselves as community-based organizations. Some of them are, most of them are nonprofits, but some of them are public entities. But they really do believe in the local delivery of supportive services that are necessary, not just nice to have, but necessary in order for older adults to be healthy. Because for the older you get, the more health care, medical health care is just not enough to stay healthy. And I think that Tracy spoke a lot about all of those other services and supports and issues that people have as they age. And so funding. The second
prong of our policy agenda is about bridging the health and social services silos. And does that resonate for anybody here? I mean, I describe it a lot of different ways. Yes, so you understand the silo. I mean, some people are always telling me, you know, I wish that I could go to the doctor and the doctor would prescribe Meals on Wheels, or, you know, connect me with this program that will, you know, bring some friends into my life. Or, you know, there's, like I said, there's more to health than healthcare. And so what we understand is that in order to make that really happen, we have to change systems. And in order to change systems, we've got to bridge, we have to hold hands and get to know the healthcare silos. And so we're working really hard to collaborate, to come together, to advocate, to bridge those silos. Educate healthcare about the power of community-based services, help them to understand how it affects their bottom line in a positive way, but it also improves health outcomes. And the third prong of our policy agenda is really focused on older adults and economic security for them, and, you know, all of the things that we've been talking about with housing and food insecurity. You know, it wraps up into that issue. Since we've been working at the county level on advocacy, because we did it at some point, I think it was in 2010, we turned our focus back to the county because we really felt that we had tilted at windmills at the state level for a long time, and we'd been able to stave off a lot of state cuts and bad policy, but you know, it's a hard fight, and we weren't getting the results that we needed. So we decided that we had partners here in the county to turn to. So we really started to focus at a county level, and our advocacy efforts focused at the county level. And we've had good results. I mean, the conversation that we have with the AAA, the planning effort that Tracy talked about, among them, but we've increased local funding, which means county funding, which means county general fund. The new Measure A, recently reauthorized by voters, has an older adult priority area with a new $1.5 million chunk of funding in that. There is cross-silo collaboration happening more and more. It's starting to happen with the county hospital system and nonprofit organizations. The process that Tracy talked about to develop this more robust AAA area plan for aging in the county created more than just the plan. It created relationships. It built relationships. When you put members of the silos together at a table and you talk about the people that they serve, it is inevitable that you get some really awesome collaborative discussions going, right? And you share about your issues and challenges, but you also learn about some innovative approaches that are right there staring at you across the table. And so the work that we've done has created collaborations that we are trying to nurture and move forward as the county is rolling out the whole person care pilot and the housing resource centers and other initiatives. So next slide. And I just wanted to, you know, I thought maybe I would just say a little bit about how we advance our policy agenda. And it really is about building relationships. You know, and it sounds so simple, but it's actually the hardest work in the world because it means you've got to be there continually over time. It's not a one-time meeting. It's really getting to know the people who sit in the other departments, in the other agencies in the county, who sit, you know, not just in the area agency on aging, but in in-home supportive services and adult protective services, but not just there, who sit in healthcare services agency, behavioral healthcare services, public health, the housing community development agency in the county. It's like really paratransit, EMS, you know, it's really getting to know and have conversations, intentional conversations with the people who are interacting in the real world with older adults and talking about what that's about, what's working and what's not, and where the gaps are. And so I think that that's maybe the most important work that our coalition does, and we do it in partnership. So, so it's been important to build our coalition beyond the members who are contracted with the AAA, and it's been really important to engage county leadership too. So we've always worked with and known the Board of Supervisors and their staff people around advocacy at the state level. But in 2010, we started to really elevate aging in their eyes and, you know, bring as much data as we could so that there would no longer be an invisible issue. And to do that, we needed to partner. So it's like, you know, you find the partners, you find the people who have the data, you find the people who are part of the system that needs to evolve, and you work together. So the other thing that I think is important to do is to recognize the innovation that's happening among the the organizations that are providing services in the community, because there are best practices and innovations, and some of them are perfectly aligned with healthcare delivery and with the gaps in healthcare delivery. So, you know, the research and the study that you do to understand that a friendly visitor program could actually do more to alleviate the anxiety of a person with COPD than multiple emergency room visits, right? And to connect the programs so that you can make that happen. And then to collect the data so that you have the results to show it. And then realize, oh my gosh, we're saving money, let's do something more. Those are, you know, that's what it's all about, and it takes working together. So it's kind of a conceptual level, my presentation, but I wanted to leave a lot of time for questions. Both Tracy and me, you know, whatever you have, throw it at us.
They're quiet today. They're not always quiet. I'll ask a question. Wendy, I saw you in the public health department. We came up in the elevator. What currently projects are you working on within the public health department or healthcare services agency?
Right. So, well, so it's interesting. So the coalition it's a coalition of all of our member organizations. So what the coalition itself does is we try to convene, we try to get those conversations going, right? But then it's not the coalition itself, it's not me, that does the collaborative work. It's you know, particular organizations. So with Healthcare Services Agency, the Whole Person Care Pilot, which in Alameda is called Alameda County Care Connect.
Yes, we had a
ACPHD.
presentation in our health and wellness committee.
Okay.
Yep.
We have on, gosh, I can't even count, I think it's 5 or more occasions we've had community-based organizations that work with at-risk, high utilizers of multiple systems, talk with, inform, and grapple with the issues that the Whole Person Care Pilot team has been looking at in order as they design the rollout of their project. And so right now, so there I think that we've built awareness in that system, in that initiative, of the power of community-based services and the particular needs of older adults, you know, that are maybe different from the younger population of chronic homeless folks that they're working with. And so I'm now sitting on the steering committee for the whole person care pilot for I have to get, you know, if I'm on the steering committee, I have to get used to the acronym, right? So, AC3, I'm on the steering committee now, with a couple of alternates who I can draw in for content expertise. So I think that's a really important one.
Thank you. And I just want to say there's an update of the Alameda County Care Connect project on the back table.
And I have,
There are more.
still working, right? I have an answer to that, and there's a little bit of history, and I have a question. Is there anyone in this room that has seen Hamilton?
Oh.
Okay, well, I wouldn't have been able to either, except a friend of a friend had an extra ticket. And we were at the very last row in the theater. But there's this great song where Aaron Burr, always feeling left out, you know, he sings, I think it's, I want to be in the room. Like, and that concept is, I got to be in the room. And that is what the Senior Services Coalition is so effective at doing, getting themselves, their partners, including us, in the room together. And so to answer your question about what's happening with public health, and I'm going to give credit to Wendy and our providers for really pushing, like, you've got to have a bigger picture vision about older adults. So the area agent, thank you.
Mic's on. Can I just look?
It isn't on.
Yeah, here. Is this? Okay, there you go.
The area agency that is so much better. So you missed that whole thing about Hamilton, didn't you? So we are working on a number of projects with public health, and one of the projects is the AAA is working with the public health nutrition services to build out gardens at low-income sites for seniors. And we started with housing sites, and now we're actually doing them at a couple of senior centers where we build out a garden, we provide technical assistance, and then the residents or the users of those sites receive nutrition education as well as the pleasure of participating with gardens. That's one project. We're working with public health, who was able, as you've mentioned, able to allocate funds to us. So $300,000 of those funds for this fiscal year and next fiscal year will go to attempt to alleviate the wait list for home delivered meals in Oakland. The newest project is working with behavioral health care that with public health as part of Healthcare Services Agency, and that's where the behavioral health care pharmacist will review those home medication lists of our older adults. And all of this is from being in the room. We wouldn't have come up with the ideas in our silos, and so we're really excited about the kind of projects that we're able to engage with public health at this point.
There's one more that I kind of want to call attention to, and that is a pilot that is being worked on right now with IHSS, which came directly out of the convenings where we just sat down together with the hospital system and Healthcare Services Agency, and that is recognizing that seniors who are living on the streets now, who are homeless, living in homeless encampments or even couch surfing, often the barrier to getting them housed is a financial one, or it's a supportive service one. There are seniors who really need, in-home supports. They need help with their activities of daily living, but when they're homeless, they can't qualify because they don't have an address, right? And so there's a pilot that's being worked on right now to kind of get around that ridiculous barrier. And either rapidly qualify someone so that they can be housed and have IHSS there, kind of same day, and so they can qualify. You know, just kind of working around those barriers that that stop the care and stop the support from happening. It's, you know what, you could call it a rule, but I think what it was a lack of you know, thought. I mean, when IHSS, it's historical. When IHSS was first developed, people they lived somewhere, right? You didn't have homeless seniors, not much at least. So you have to have an address. The box isn't checked if there's not an address listed, the application doesn't go anywhere.
The part of government that is somewhat onerous at times.
I have the same issue with homeless veterans, and they've had to go through the same kind of thing, and they don't have an address. And so I know there's been some work with some of the veterans organizations to try to solve that. I don't know how it's done, but PO box type of thing where there's a home base somewhere for them, but it is veterans as well.
Right, yeah, and with homeless seniors who really need these supports, they really do need them. And so, you know, often it's, they have family, but the family can't accommodate them because they don't, you know, they're low income too. And so sometimes, you know, having an IHSS worker who is your family member can create some economic security from the family, and it can be the thing that opens the door to the family saying, yeah, we can take Dad in and take care of him. So that too, yeah.
I think traditionally, the developmental disability community and the regular services for the aging have been siloed. And I think there are several reasons for that. I think that the aging community may be a little afraid of our people, think they need more support, it could be a drain of their resources. And also that we have our own system. But IHSS is one thing that has crossed the barrier. And I think one of the other places that we've been able to sort of break in has been in senior centers, because some of our people do very well in senior centers. They don't need any support from some of the other people. But I suspect that a good number of homeless centers are also developmentally disabled persons that haven't been identified and aren't in the DD services.
Yeah, and so that's something to work on.
Absolutely.
Question to ask.
We're not short of work here.
Yeah.
And your discussions, I've heard,
Here, can I? I'm
older
gonna
adults.
borrow yours, 'cause, no, but Gwen, you have such a soft voice.
Yeah. Thanks. In both of the discussions today, I've noticed you say older adults, and I'm thinking, okay, what age is older adults? And I've heard 60 and I've heard 65. Does it matter? That
Well, it's.
We're laughing because I can't even begin to tell you how much time this took on the planning. Like, what term do we use? And there was a point where, yeah, I think in the plan at one point I had to search and replace because I had seniors, and it was 78 incidents. Our planning committee did reach consensus that the term should be older adults. And the planning committee was actually interested in even looking at maybe like 50 or 55 years old. The Older I know, right? The Older Americans Act defines an older adult as 60. From a census perspective, we can get the best data on 65 plus. So it's a moving target.
Yeah.
I have a 61-year-old, so that's why I was asking.
Your 61-year-old is eligible for Older Americans Act services.
She looks good, doesn't she?
Yes.
Tracy and Wendy, thank you for coming on out. I got a two-part question. One is on legislative. Is there any legislative things that are coming up that we should be keeping our eye on and promoting or opposing?
Oh gosh, I wish I brought my list.
So yes, and I want to say that one of the things that really came out of this planning effort is that we as a community have to work much better on advocacy and legislation. It's a concrete goal that we have. We actually were able to hire a staff person that is able to look at Wendy, the Senior Services Coalition, my statewide associations coalition, the county associations coalition, and we are starting to work through the process in order to be more effective. One piece of legislation that we're actually having our board, I think, address maybe on Monday or Tuesday is new legislation that asks AAAs to have an information and assistance specialist that is particularly knowledgeable about dementia. So that's brand new legislation. It does not yet have funding attached to it. Our statewide association proposed that legislation, and we of course want to have funding attached to it. But I think that's really important that across the state, we can make sure that there are dementia experts that can at least give basic information. To answer your larger question, yes, there, oh good, Wendy is gonna answer more.
I mean, well, there are a lot of bills. I mean, there really is, there are multiple pages of bills that are sort of interest, but, and I think that every organization or group needs to kind of look at them and decide what your priorities are, because you can't be writing letters on 100 bills. It's, you know, it's too much work. But AB 614 is the one that Tracy was talking about. I actually have a list of bills that are, you know, I think that they've been vetted by the organizers of the senior rally that's happening in Sacramento tomorrow, and then the Senior Services Coalition here has looked at kind of a broader list, and so I could send that list to you, Sandy, and so you could look at it. I think one of them is an interesting one. It's SB 62, and it establishes the Affordable Senior Housing Program within the existing state GoBiz initiative, which means that a lot of government assistance in identifying, locating, doing all of the regulatory prep work, and finding the funding for senior housing in GoBiz identified regions, you know, would be there. Right now, senior housing isn't a part of that, so that one's interesting. There's funding for caregiver resource centers. There is, of course, reinstating the SSP cost of living, and there is a bill, AB 1200, which would basically codify into state law the ADRCs, which aren't currently funded, but that is a mechanism that has to be in place at the state level in order for any funding to come down from the feds. So if there is funding for ADRCs in the future at the federal level, we need this sort of like hook at the state level in order to get some of it, right? And it's not there now, so that's a really important bill that we hope makes it. It's AB 1200.
Oh, 1200.
Cervantes, yeah. And I'll send Sandy this list.
Well, that is a bill that our legislative coalition, the East Bay Legislative Coalition, has supported. I know Ron can speak to that, but I think it's an important bill. And it's also illustrative, which I can't thank you enough, bless you too, Wendy, for mentioning the collaborative efforts and the importance of that. And I think working with the ILCs in Alameda County with Krill and CIL is just a wonderful example of that collaboration.
Yeah.
And I have a question. Does this group have a legislative platform? Because if you do, and if you share it with us, then also we can incorporate that in our thinking, and would love to.
I have one more
Yes.
question. With the passing of, through the House for the, what is that called again, American Health Care Act?
Mm-hmm.
Now it's going to the Senate. There is a thing called I am a pre-existing condition, and it's due today. It's the 10th. Are you guys working on this? It's basically a personal video, taking it, and we're trying to promote it and send it up to Washington. Are you guys doing anything with senior citizens for this?
I haven't heard of it. Wendy, have
Yeah,
you?
we've, so what we've done we realized in December, we realized in November that, that we would need to be doing work at the federal level. But it's really important for us to understand what we can do and what other people are doing, and we can just like connect our members and our community to. So we're working in a connective way there. So we've sent out that information. I think
to
it's
our Facebook page.
okay. That's a good one.
Yeah, and then just go to Krill's Facebook page, and then send it out to everyone. Again, it's due today, so we're trying to get it out as many videos as possible.
Yeah, that's a hard one. I wish it was due tomorrow because the senior rally is happening tomorrow, and that would be a perfect time to do some work around that.
To speak of Facebook, and I'll look at the meeting talking about more disabilities.
Okay.
And then I'll give this for Sherry.
I put out what Ron's talking about. I am an existing condition. I put that out yesterday. You should have that in there.
And we have a couple more questions. We can, thank you, like Wendy, we can send out the request via email if you send me something, and we can do that when I get back to the office. I believe that there's a question from the gentleman next to you,
Yes.
to your left front.
I'm just curious because I don't know, because it just passed or repealed Obamacare, and you guys were talking about it, but they're talking about, he said no, but I don't trust Trump, but the pre-existing health care won't be addressed as, from what I understood, it was in Obamacare. And I was wondering what you guys thought of that. I haven't read anything to know right or wrong, but I have cerebral palsy, I'm a senior, and Obamacare was fine for me, but I don't wanna see it taken away from people that really need it, and I know that you're on our side, but I don't know, I mean, they've already passed the other one to appeal it, but that was one of the things I've heard was that the pre-existing, it will have to pay more. I don't know if it's scare tactics or the truth or whatever yet, but I want to know your opinion on it if you can.
Right. So the House bill that passed, the American Health Care Act, was not scored by the Congressional Budget Office, but the previous bill that is sort of like the one that passed scored pretty badly, and so. And whether that's scare tactics or, well, I don't think it is. The Congressional Budget Office is a bunch of people with eye shades who are so not political. Their numbers are pretty much right on. But I think I want to say about what Congress passed. That bill went on to the Senate, and the Senate is a very different deliberative body than the House. The House bill was sort of like a grab bag of all of these different ideas, sort of not put together in any sort of cohesive policy. The Senate, from what every senator on both sides have said, is that they're going to start pretty much from scratch. They're not going to tweak the bill that came from the House. They're going to start over. And so it's a long process, and we don't really know what's going to come out of the Senate. I think what we do know now is what's important to us as people living in the United States for our health care. And so I think in terms of advocacy, don't wait. Let your congressional representatives and senators know how important these different parts of the healthcare system are to you, and you don't have to be an expert. You can just tell your stories and you can tell them what's important to you. But when the Senate comes out with their version, then we'll have something concrete that's scored, so we really know what the impact is. And, you know, I think you'll hear about that.
I think we're having problems with computers here.
Oh, not ours.
Sounds like a network problem.
All right, any other questions here? Okay, wonderful. Thank you, ladies, so much.
Thank you. It's been fun, thank you.